Welcome back to the Deep Dive. Today we are doing something a little different. We aren't just exploring a topic, we are essentially simulating a war room.
A prep session.
Exactly. We are preparing for one of the most high-stakes moments in an anesthesiology residency, the MD final exam. Specifically, we're targeting that one long case that makes even the most confident postgraduates sweat congenital heart disease, or CHD.
It really is the topic everyone hopes to avoid, but, statistically, you just can't hide from it.
No way out.
No. Whether it's a 20-mark theory question on the Gujarat University boards or a Viva station where they hand you an ECG and a chest x-ray of a blue child, CHD is. It's inevitable. And frankly, I think the fear comes from a lack of a structural understanding. It just feels like this chaotic mix of holes and valves and weird connections.
Right, it feels like a total mess.
But it's not. It's actually just plumbing. At the end of the day, it's physics.
Physics and pressure gradients. I like that framing. It simplifies things. Okay, so to help us navigate this plumbing, we've pulled together a stack of heavy hitters.
The essential.
We have objective anesthesia review for that clinical structure, the legendary Miller's anesthesia for the deep physiology, core topics, and cardiac anesthesia for some of the management nuances, and we've even combed through past DNB and university question banks.
So we're going to treat this session like a high-intensity tutorial. I'll take on the role of your senior faculty, or maybe the external examiner, the one who isn't satisfied with the textbook definition and wants to know if you really understand the why.
And I'm the candidate.
You're the candidate.
I'm in the hot seat. I've got my imaginary nightpad, my stethoscope is around my neck, and my palms are already a little bit sweaty. So let's start at the very beginning. Part A, introduction and exam framing. If I'm standing before a patient or, just staring at a blank answer sheet, how do I even start to frame the definition of CHD without sounding generic?
You have to be precise. That's the first rule. Don't just say heart defects.
Okay.
Based on Miller and core topics, the gold standard definition, the one you should write down, is structural abnormalities of the heart or intrathoracic great vessels that are present at birth.
Okay, structural abnormalities present at birth. Got it.
But you cannot stop there. This is the part that separates a good answer from a great one. You must immediately add the functional consequence.
So what it does?
What it does, you add. These defects alter normal flow and pressure relationships, the hemodynamics.
So it's structure plus consequence.
Exactly. A hole in the heart is just anatomy. The fact that blood flows from the left ventricle to the right ventricle because of a pressure gradient, that is the physiology. That's what puts the patient at risk, and that ultimately is what the anesthetist manages.
That makes sense. Now, looking through Miller, there's a really strong emphasis on the changing landscape of this disease. Why is CHD becoming such a critical topic for general anesthetists now, and not just the cardiac super specialists?
It's a victim of its own success, really. 30 years ago, a child with a complex lesion like Tetralogy of Fallot or a transposition, they often didn't survive to adulthood. Today, with vastly improved pediatric cardiac surgery, they are surviving. Miller has a whole section on this, the grown-up congenital heart, or GUCH population. You'll also see it as ACHD adults with congenital heart disease.
So these patients are now, 25, 30, 40 years old?
Precisely. And they aren't coming to the hospital for heart surgery anymore. They're coming in for laparoscopic cholecystectomies, for C-sections, or for emergency trauma surgery after a car accident.
And they end up on the operating table of a general anesthetist who might not have thought about shunts since their second year of medical school.
Exactly. And the physiology is a whole different ballgame. As Miller points out, the pediatric patient is dealing with issues of organ maturation. Their myocardium is stiff, their sympathetic nervous system is still immature. But the adult with repaired CHD, they are dealing with the sequelae of the repair and the chronic disease. They have scar tissue on the heart, which means they're prone to arrhythmias. They have chronic ventricular failure. They might have developed pulmonary hypertension over decades.
So you're anesthetizing a scarred, compensated, and often fragile heart.
That's the perfect way to put it. It's a crucial distinction for your exam answer.
Okay, so in that exam context, looking at something like the DNB question bank, what are the frequent flyer questions, the ones we absolutely need to be ready for?
You need to have 3 preloaded templates in your brain, ready to go.
I'm ready.
Number 1 is a classification question. Classify congenital heart diseases. That can be a 10 or even a 20 marker, depending on the year.
Okay, classification.
Number 2 is the case management question. It will be something like, a 5-year-old with Tetralogy of Fallot is posted for brain abscess drainage. Discuss your preoperative evaluation and intraoperative management.
And number 3.
Number 3 is the physiological diagram. Explain with diagrams the hemodynamics of a patent ductus arteriosus or a VSD or something similar.
Hold on, you said brain abscess drainage. That sounds so specific. Is that a common pairing with CHD?
It is a classic exam setup, a total examiner favorite. Objective anesthesia review highlights this constantly. In cyanotic heart disease, where blood shunts from right to left, you lose the filtering function of the pulmonary capillaries.
So the lungs are a filter.
A critical one. Normally, bacteria from your gut or skin get into the venous system. They get trapped and killed in the lungs. But with a right to left shunt, they bypass the lungs completely. They go straight from the right heart to the left heart and out into the systemic circulation.
And they can lodge in the brain.
And lodge in the brain, causing an abscess. So if you get a case of a child with a brain abscess, you must have a high index of suspicion for an undiagnosed cardiac shunt.
That is a gold nugget connection right there. A true clinical pearl for the exam. Okay, let's move on then. Part B, classification. You mentioned this is a huge potential question. I feel like this is where students, myself included, often get tangled up between, clinical and anatomical and physiological descriptions.
They do, and it annoys examiners because it shows a lack of clarity. Keep it clean. Start with the simplest, most useful framework. The clinical classification found in objective anesthesia review.
Okay.
2 big buckets, acyanotic and cyanotic.
Pink versus blue.
Pink versus blue. As simple as that. Acyanotic, or pink, usually implies a left to right shunt. Oxygenated blood from the high-pressure left side of the heart goes back to the low-pressure right side and gets recirculated to the lungs.
And those are our ASDs, VSDs, PDAs.
Your atrial septal defects, ventricular septal defects, and patent ductus arteriosus, the classic ones.
And cyanotic.
The blue babies. That implies a right to left shunt. Deoxygenated blue blood bypasses the lungs and goes directly into the systemic circulation. The patient looks blue. This is your classic tetralogy of Fallot, or transposition of the great arteries.
Okay, that seems simple enough to start with. But I do see in Miller there's a more complex physiological breakdown. Should I be using that?
You should. If you want to impress the examiner, and in Aviva, you absolutely do. You use the physiological classification. It shows a deeper level of understanding.
Okay, so how does Miller break it down?
It's broken down by the functional mechanism. So, Category 1, shunts, which we've just discussed, your ASDs, VSD, and PDAs.
Right.
Category 2, mixing lesions like truncus arteriosus, where there's basically one big common vessel and everything just mixes together. Category 3, stenotic lesions, which are obstructions like pulmonary stenosis or aortic stenosis. And finally, Category 4, regurgitant lesions like valve incompetence.
I see. So starting with acyanotic, cyanotic, and then adding the physiological layer shows you understand the mechanism, not just a memorized list.
Precisely. It's a much more sophisticated answer.
Speaking of mechanism, let's go deep into Section 3, the physiology of shunts. This feels like the engine room of this whole topic.
It is. I will say this again. If you understand shunts, you can manage any case, even if you forget the name of the syndrome. It all comes back to the shunt.
So let's start with the left to right shunt, the VSD or PDA.
Okay. The pressure in the left ventricle, your systemic pump, is, let's say, 100 millimeters of mercury. The pressure in the right ventricle is maybe 25. If there's a hole between them, where does the blood go?
Down the pressure gradient, left to right.
Down the hill, correct. So blood that has already been nicely oxygenated in the lungs and should be going to the body is essentially wasted. It goes back to the lungs for another trip.
So the lungs get too much blood.
Way too much. Miller calls this pulmonary overcirculation. The lungs are flooded, plethoric, wet. That's a key term.
And what does that constant overcirculation do to the heart itself?
It causes volume overload. But here is the classic trick question, a favorite for Vivas. In a patent ductus arteriosus, which chamber of the heart experiences volume overload and eventually fails?
Okay, let me think. The PDA connects the aorta to the pulmonary artery. So the extra blood goes into the pulmonary artery.
Yeah.
So the right ventricle.
That is the trap, and it's a very common mistake.
Oh, no.
Trace the path. The blood goes from the aorta to the pulmonary artery, yes. But then where does it go? Through the lung.
Into the pulmonary veins.
Which drain into the air.
The left atrium And then the left ventricle.
Exactly. So the left ventricle ends up pumping its normal stroke volume to the body, plus all the shunt volume that just came back from the lungs again. A PDA causes left ventricular volume overload.
Ah, that makes total sense when you trace the complete circuit. The LV is doing double duty.
It is. Now let's flip it. Let's talk about the right to left shunt, or classic Tetralogy of Fallot. In this case, the resistance to getting out of the right ventricle and into the lungs is very high. The valve is blocked, or stenosed.
Right.
So blood takes the path of least resistance. It escapes from the RV through a VSD and directly into the aorta. The lungs are bypassed. They are allogemic, or dry.
So the main issue there isn't volume overload. It's profound hypoxia.
Hypoxia, cyanosis, and the risk of emboli. Now, here is probably the most important part of this entire deep dive. These are what I call the anesthetic control knobs.
Oh,
As an anesthetist, you have two main knobs on your console that you can turn to control the situation. SVR, which is systemic vascular resistance, and PVR, pulmonary vascular resistance.
the resistance in the body versus the resistance in the lungs.
Exactly. And the ratio of SVR to PVR is what dictates how much blood shunts and in which direction.
Okay, so let's apply that. In a right to left shunt like TOF, where we want more blood to go to the lungs to get oxygenated, how do we tweak those knobs?
Think about it logically. The blood sitting in the right ventricle has a choice. It can go the hard way through the stenosed pulmonary valve to the lungs, that's PVR, or it can go the easy way through the VSD to the aorta, that's SVR.
We want it to take the hard way.
We want to encourage it to go to the lungs, so we need to make the easy way harder. We need to increase SVR.
Okay, clamp down on the systemic circulation.
And if we can, we want to make the hard way a little easier. We need to decrease PVR.
Maintain or increase SVR. Decrease PVR. I am writing that in giant letters. That's the mantra for TOF.
It is the single most important principle. Because if you do the opposite, say you induce your patient with a big bolus of propofol, which is a potent vasodilator, or you give a spinal anesthetic, what happens to SVR?
It plummets.
It plummets. You open the floodgates to the aorta, all the blood takes the new path of least resistance, it bypasses the lungs entirely, the patient's saturation drops to 40%, and they have a cardiac arrest. You have essentially killed the patient on induction.
That is a terrifyingly vivid picture. High SVR is life in TOF.
It absolutely is. Conversely, in a left-to-right shunt, like a PDA, if you increase SVR too much, you just force more blood back into the already fled lungs. So it's always a balance. But the TOF and SVR relationship is the critical safety one to remember.
Okay, let's broaden out a bit. Part C, general anesthetic considerations. Before we even get to the specific lesions, what are the universal rules we need to follow for any CHD patient? Miller talks a lot about ventilation strategies.
Ventilation is hemodynamic management in these patients. You cannot separate them. We just talked about PVR, right?
Right.
Well, what affects PVR? Your ventilation. What are the things that increase PVR? Hypoxia, hypercarbia, which is high CO2, acidosis, and using high levels of PEEP, positive end expiratory pressure.
So if I have TOF patient and I'm not careful, maybe I let their airway obstruct for a minute, their CO2 starts to rise.
As soon as the CO2 rises, the pulmonary vessels constrict, PVR goes up, the right to left shunt immediately worsens, the patient gets bluer. It's a vicious cycle. So for a TOF patient, our goal is gentle ventilation, low normal CO2, and perfect oxygenation to keep that PVR as low as possible.
Okay, that makes sense. What about the blood itself? Objective anesthesia review talks a lot about polycythemia.
Yes, this is a classic physiological compensation. The body is chronically hypoxic, so the kidneys get a signal to churn out more erythropoietin.
The hormone that tells the bone marrow to make red cells.
Precisely. So the bone marrow goes into overdrive. You'll see these patients with hematocrits of 60, 65, sometimes even 70%.
Which sounds good for oxygen carrying capacity, right? More red cells, more oxygen.
In theory, yes. But in practice, the blood becomes like sludge or ketchup.
Hyperviscosity.
Extreme hyperviscosity. This leads to sludging in the microcirculation and a very high risk of thrombosis. We're talking strokes, DVTs, renal vein thrombosis. But, and here's the exam paradox you have to mention, these patients also have a bleeding tendency.
Wait, how can that be? They're prone to clots and they're prone to bleeding.
Yes. It's a cruel irony. The huge mass of red cells consumes clotting factors, particularly fibrinogen. Also, the platelets are often dysfunctional because of the chronic high-flow, turbulent states and the hypoxia.
So you have thick blood that doesn't clot properly.
Exactly. You cut into them during surgery and they just ooze uncontrollably from every surface. You have to be ready for coagulopathy despite the thick blood.
That is a nasty combination to manage.
Mm.
I also see a big warning note here about paradoxical embolism. You touched on this with the brain abscess.
This is a standard Viva safety check.
Okay.
The examiner will almost certainly ask you about this. If you have a shunt, an ASD, VSD, TOF, any hole, there's a direct connection between the venous side of your circulation and the arterial side.
Okay.
If you are sloppy with your IV lines and you inject a tiny bubble of air,
Normally that bubble just goes to the right heart, gets pumped to the lungs, and gets trapped and dissolves in the capillary.
correct. The lungs are our natural bubble filter. But with a shunt, that bubble can cross from the right side to the left side, go into the left ventricle, get shot up the carotid artery, and occlude a cerebral vessel, a stroke.
From a tiny air bubble.
Or it could go into a coronary artery, an MI. Therefore, the absolute non-negotiable rule is meticulous de-airing. All 5 lines must be flushed perfectly, no air. Use bubble filters on your lines if you have them. If the examiner asks, you are inducing a TOF child, what is your first safety check? The answer is not check the airway. The answer is I check my IV tubing for air.
That's a huge takeaway. Okay,
Please.
let's talk about seeing the patient before surgery. Section 5, the pre-op assessment. The patient is in the clinic. What are the key things we're looking for?
First, just look at the child. Are they blue at rest? Do they have clubbing of their fingers and toes? Clubbing tells you that the desaturation is chronic and it's significant.
And then the history.
Ask about functional status. In a child, that doesn't mean asking about me-tees. It means asking the parents. Can they keep up with their friends when they play? Or do they turn blue when they cry or when they're feeding?
And specifically for Tetralogy of Fallot, we ask about squatting, right?
Absolutely. Squatting is a fascinating compensatory behavior. We'll explain the exact physiology of it when we get to the TOF section, but a history of frequent squatting is a massive red flag for severe outflow tract obstruction.
Got it. What about NPO guidelines? Fasting before surgery.
This connects directly back to the polycythemia and hyperviscosity we just discussed. Miller gives a very strict warning about this. Dehydration is extremely dangerous.
Because it makes the sludgy blood even sludgier.
Exactly.
Yeah.
If a polycythemic patient gets dehydrated, their blood viscosity shoots up even further, and they are at a huge risk of clotting off a major vessel. So you do not starve these children for 8 or 10 hours.
So liberal fluids.
You follow the 6-4-2 rule strictly. Encourage clear fluids up to 2 hours pre-op. If the surgery gets delayed for any reason, you must start an IV and run maintenance fluids. Keeping them well hydrated is effectively an antithrombotic therapy for them.
Okay, I think that's a great foundation. Let's get into the main event. Part D, Tetralogy of Fallot. The classic blue baby.
If you get a long question on CHD in your exam, there is probably an 80% chance it will involve TOF. It is the archetype of cyanotic heart disease.
So we have to know this inside and out.
Yeah.
Let's drill the definition. Why is it a tetralogy? What are the 4 components?
You must memorize this list. This is straight from Objective Anesthesia Review, and it's non-negotiable. 1. A VSD, a ventricular septal defect, which is usually large and non-restrictive.
Okay, a hole between the ventricles.
2. RVO20, which stands for right ventricular outflow tract obstruction. This is the key problem. It's usually a stenosis of the pulmonary valve or a muscular spasm of the infundibulum just below the valve.
Obstruction to lung blood flow. Got it.
3. An overriding aorta. The aorta shifts over to the right and sits directly on top of the VSD, so it's accepting blood from both the right and the left ventricles.
And 4.
4 is RV hypertrophy, or a thickened right ventricular muscle.
Yeah.
This isn't part of the primary defect. It's a secondary consequence of the RV having to pump for years against that high-pressure obstruction.
VSD, RVO20, overriding aorta, RV hypertrophy.
Yeah.
Got to burn into my brain. Now, can you explain the pink tet versus blue tet concept? I've seen that mentioned.
Of course. It's all about the competition for blood flow. Imagine you're a red blood cell in the right ventricle. You have 2 doors you can exit through. Door A goes to the pulmonary artery, to the lungs, or B goes through the VSD to the aorta, to the body.
Okay.
In a classic blue tet, door A is severely blocked by the stenosis. It's very high resistance. So most of the blood takes the easy way out, door B, that's a big right-to-left shunt, and the patient is cyanotic.
Makes sense.
In a pink tet, the stenosis is much milder. The resistance of door A is actually less than or equal to the systemic resistance of door B. So the blood preferentially goes to the lungs. They might have a balanced flow or even a small left-to-right shunt. They look pink at rest.
But the anesthetic management always has to assume the worst-case blue scenario, right?
Yeah.
Always prepare for the blue scenario, because even a pink tet can turn profoundly blue in an instant if you, for example, drop their systemic vascular resistance. You can create a tet spell.
Okay, let's talk about that squatting mechanism again. We said it's a red flag. But why does a 4-year-old child intuitively know to squat when they feel breathless?
It's a brilliant, intuitive piece of mechanics. When a child squats, they kink the femoral arteries in their legs.
Okay.
This mechanically increases the afterload on the left ventricle. It increases the systemic vascular resistance. Now go back to our doors analogy. Squatting makes door B, the aorta, much harder to open.
So the blood is forced to reconsider door A.
Exactly. By increasing SVR, the child forces more of the right ventricular output to go into the pulmonary circulation, which relieves their own hypoxia. They are, in effect, auto-resuscitating themselves.
That is absolutely incredible. They are performing their own physiological intervention.
Nature finds a way.
Okay, Section 9 is a big one. Anesthetic goals. You gave us the mantra earlier, maintain SVR, decrease PVR. How do we actually operationalize that in the OR with our drug choices?
Let's break it down by categories. For induction, you want an agent that maintains or ideally increases SVR. The gold standard here, without a doubt, is ketamine.
Okay.
For volatile agents, something like sevoflurane is smooth and great for kids, but it is a vasodilator. It will lower SVR. You have to be very, very careful with it and titrate it slowly.
Bench fluids.
For fluids, you have to remember that hypertrophied RV is stiff. It's non-compliant. To generate enough pressure to pump blood past the stenosis, it needs to be well filled. It is preload dependent, so you must keep the tank full. Hypovolemia is disastrous.
So no fasting and keep the fluids running.
Absolutely. A dry TOF patient is a patient on the verge of collapse.
Now let's talk about the TET spell. This is the nightmare scenario intraoperatively or in the recovery room.
The hypercyanotic spell. It's a true medical emergency. This happens when the infundibulum, that muscular area right below the pulmonary valve, goes into a sudden, severe spasm.
It just clamps shut.
It clamps shut. Pulmonary blood flow drops to near zero. The child turns deeply, profoundly blue. They may have a seizure from hypoxia or go into full cardiac arrest. And the triggers are anything that releases catecholamines: crying, pain, anxiety, defecation, or light anesthesia.
So I'm in the Viva. The examiner sets the scene. You were in the recovery room. Your post-op TOF child starts crying and turns black. What do? I need the step-by-step.
Don't waffle. You need to give the protocol from objective anesthesia review clearly and calmly. Step 1, 100% oxygen. Even though it's a flow problem, not a lung problem, you want to maximize any dissolved oxygen in the blood.
Okay, oxygen first.
Step 2, knee-chest position. If they're awake, you tell them to tuck their knees up to their chest. If they're anesthetized, you or the surgeon manually flex the hips. You are mimicking squatting to spike the SVR.
Okay, increase SVR physically.
Step 3, morphine. Give a dose like 0.1 milligrams per kilogram IV or IM. This is absolutely crucial. It sedates the child, which stops the crying and the catecholamine surge. It reduces the respiratory drive, which stops the air hunger and panic. And it may have a central effect that helps relax the infundibular spasm.
So sedation is key.
Step 4, fluids. Give a fluid bolus, 20 mils per kilo, to stretch that stiff RV and hopefully pop open the outflow tract. Step 5, vasopressors. This is the drug choice that fails students in the exam. You need a pure alpha agonist. The drug of choice is phenylephrine,
Why phenylephrine specifically?
because you want to clamp down the systemic vessels to raise SVR without whipping the heart into a faster, more forceful contraction.
So why not epinephrine? I mean, it's basically a cardiac arrest, isn't it?
Do not use epinephrine. This is a big trap. Epinephrine has powerful beta-1 activity. It increases myocardial contractility. If you increase the contractility of that already spasming infundibular muscle, it will spasm even tighter.
Wow.
You will make the obstruction worse. Epinephrine is absolutely contraindicated in a TET spell.
That is the trap. No inotropes. Only vasoconstrictors.
Correct. And if things are still not improving, step 6 is to consider beta blockers. A small dose of esmolol or propranolol can help to pharmacologically relax that infundibular muscle and also slow the heart rate to allow for better ventricular filling.
That is a concise, life-saving algorithm. So phenylephrine and maybe esmolol. Definitely avoid epinephrine. Let's circle back to the induction logic you mentioned, ketamine.
Yeah.
Normally, cardiac anesthetists kind of hate ketamine because it causes tachycardia.
That's true. In something like ischemic heart disease, tachycardia is a very bad thing. But in TOF, ketamine does something magical. It causes the release of endogenous catecholamines, which primarily constrict systemic vessels. It boosts SVR.
Right.
By boosting SVR, it actively reduces the right to left shunt. You'll often see the patient's saturation actually improve, and they get pinker after a dose of ketamine. It truly is the induction agent of choice.
And what about an inhalational induction with gas?
Ugh. There's a fascinating physics principle here. It's about the FOFI ratio, the ratio of alveolar to inspired concentration of the gas. In a right to left shunt, an inhalational induction is significantly slower than normal.
Slower. Why is that?
Because a large portion of the venous blood bypasses the lungs entirely. That blood never sees the sevoflurane.
Ah, so it never picks up the gas.
It never picks up the gas. It then mixes with the small amount of anesthetized blood in the left heart and dilutes it. So the concentration of anesthetic reaching the brain rises very, very slowly.
Okay. And what about IV induction?
Conversely, 5E induction is faster than normal.
How?
Because the high-B drug, say propofol or ketamine, goes into the vein to the right heart, crosses the VSD, and goes straight to the brain, bypassing the first-pass uptake by the lungs that would normally slow its onset.
5E induction is faster, gas induction is slower. That is a classic MCQ right there.
Memorize it. It's a guaranteed point.
Okay, that feels really solid for TOF. Let's pivot now to the other end of the spectrum, Part E patent ductus arteriosus, the PDA.
Yes, the PDA. This is our classic left-to-right shunt. It's simply the persistence of the fetal connection between the aorta and the pulmonary artery.
And in the fetus, this connection is necessary, right?
It's vital. In utero, the lungs are filled with fluid and the PVR is very high. The ductus allows blood from the right ventricle to bypass the non-functional lungs and go straight to the descending aorta.
But after birth?
After birth, the baby takes that first big breath, the lungs expand, oxygen levels in the blood rise, and PVR plummets. This change in oxygen tension and the drop in circulating prostaglandins should cause a ductus to constrict and close within a few hours or days.
And if it stays open, you have a problem.
You have a high-pressure hose, the aorta, feeding directly into a low-pressure pipe, the pulmonary artery.
And that's what creates that classic continuous machinery murmur.
It's continuous because the pressure in the aorta is higher than the pressure in the PA during both systole and diastole. The flow never stops. It's just a constant whoosh of blood into the lungs.
Let's look at the pathophysiology in section 13 again. We said it before. Pulmonary overcirculation and left ventricular volume overload.
Correct. The lungs are constantly wet and flooded. This is why these babies have frequent respiratory infections, poor feeding, and failure to thrive. They're also very difficult to ventilate because their lung compliance is terrible. The lungs are stiff and boggy.
And the long-term risk here is something called Eisenmenger syndrome, right?
Yes, and this is the point of no return. If you leave a large PDA untreated for years or decades, that high-pressure, high-volume flow relentlessly hammers the delicate pulmonary arterioles.
They get damaged.
They get damaged, they undergo remodeling, they thicken, they scar. The PVR, which was once low, begins to rise permanently. Eventually, the PVR will rise so high that it exceeds the SVR.
And the shunt reverses.
The shunt reverses. It becomes a right-to-left shunt. The patient turns blue. At that point, the game is over. Surgery is contraindicated. You cannot close that hole anymore because it's acting as a pop-off valve for the failing right heart. If you close it, the right heart will fail immediately.
So we have to intervene before that irreversible pulmonary hypertension sets in.
Exactly.
Okay, let's talk about section 15. Anesthetic goals for a PDA. There's a very specific oxygen trap mentioned here, particularly for premature neonates.
This is a huge concept in the NICU and a very high-yield topic for the exam. Oxygen is a drug.
Right.
And in the pulmonary vasculature, oxygen is a potent vasodilator. So if you have a premature infant with a large PDA and you decide to blast them with 100% oxygen,
You're going to drop their PVR.
you're going to drop their PVR to near zero. And what does that do to the shunt?
It makes it way bigger. More blood will rush from the aorta into the lung.
A torrent of blood.
Okay.
And that blood is being stolen from somewhere else.
The rest of the body.
Exactly. It's called ductal steal. You are stealing blood flow from the systemic circulation, from the gut, which can lead to necrotizing enterocolitis, from the kidneys, causing renal failure, and from the brain.
So what's the goal then?
In a large PDA, especially in a preemie, we often practice permissive hypoxemia or controlled saturation. We aim for an SpO2 of maybe 90 to 95%. We do not aim for 100%. The last thing we want to do is aggressively dilate the pulmonary bed.
That is so counterintuitive for an anesthetist. Our instinct is always give 100% oxygen.
It is, and being able to explain why you wouldn't do that is what separates the novice from the expert.
What about the surgery itself, the PDA ligation?
It's usually done through a left thoracotomy. The surgeon goes in between the ribs, retracts the lung, finds the ductus, and puts a clip or a suture on it.
What's the main danger zone for us?
The danger zone is the clamping itself. The surgeon is working in a very crowded space right next to the aorta, the main pulmonary artery, and the recurrent laryngeal nerve. So you need 2 pulse oximeters.
2? Why?
One on the right hand, which is preductal, and one on a foot, which is postductal.
And what does that tell you?
It's to catch a catastrophic error. For instance, if the surgeon accidentally clamps the aorta distal to the left subclavian artery instead of the ductus, you will immediately lose the pulse and saturation in the foot, but the hand will be fine.
Ah, I see. It's a safety monitor.
It is. If they clamp the left pulmonary artery by mistake, your overall saturations will change dramatically. And you have to watch out for the recurrent laryngeal nerve. It loops right around the ductus on the left side. Injury to that nerve is a very common complication, leading to hoarseness or a weak cry post-op.
One final physiological point on the PDA. What happens to the heart the exact second the surgeon's clip goes on?
This is a great point. It's called afterload mismatch. The left ventricle has spent its entire life pumping blood into a low-resistance system because of that runoff hole into the pulmonary artery.
Right.
Suddenly you plug the hole. The systemic vascular resistance that the LV has to pump against shoots up instantly. The LV faces a sudden, massive wall of afterload.
And a weak, volume-overloaded ventricle might not handle that well.
It might fail. Acute left ventricular failure is a real risk right at the moment of ligation. You need to be ready with inotropes or vasodilators to help the heart adjust to its new reality.
That's a fantastic clinical detail. Okay, let's try to bring this all together. Part F comparison and exam integration. We need to synthesize this for the exam answer.
Let's do a rapid-fire contrast table. TOF versus PDA.
Okay, get me.
Shirt direction. TOF is right to left, so they're blue. PDA is left to right, so they're pink.
Okay.
Lung blood flow. In TOF, the lungs are allogemic or dry. In PDA, the lungs are plethoric or wet.
Right.
Induction strategy. For TOF, your best friend is ketamine to keep SVR high. For PDA, you have to be careful with oxygen to avoid dropping the PVR too low.
And manage it.
Overall management. TOF is all about maintaining preload with fluids and using phenylephrine to support SVR. PDA is often about fluid restriction, diuretics, and using PEEP to manage the wet lungs. They're polar opposites.
That's the perfect cheat sheet. Now let's revisit those Viva tracks. We've talked about the air bubble and the epinephrine trap and TED spells. What else?
The SVR trap in a non-cardiac surgery for a TOF patient. The examiner will ask, a 5-year-old with unrepaired TOF needs a hernia repair. Would you do a caudal or a spinal anesthetic?
And the answer is?
The answer is be very, very cautious. Regional anesthesia, whether it's spinal or epidural, creates a chemical sympathectomy. It will drop the SVR.
And if you drop the SVR in TOF?
You can precipitate a massive right-to-left shunt and a cardiac arrest. So if you absolutely must do it, you have to treat it like a loaded gun, have phenylephrine drawn up and ready, preload them aggressively with fluids. But honestly, a carefully managed general anesthetic is often much safer because you have moment-to-moment control over the hemodynamics.
Got it. Okay, section 19 mentions diagrams. The DNB questions love asking for diagrams. How do I draw a heart in 3 minutes under exam pressure?
Do not try to draw an anatomical heart with shading and coronary veins. It's a waste of time. You draw the box diagram.
Box diagram.
Draw a simple square and divide it into 4 quadrants. Label them RA, RV, LA, LV. Then draw the pipes coming out the top aorta and PA. For TOF, draw a gap in the septum between the ventricles. That's your VSD. Then draw the aorta shifted to the right so it straddles that gap. Make the pipe for the pulmonary artery look really narrow. Finally, draw a big fat blue arrow going from the RV through the VSD and into the aorta. Label it R2L Shunt.
Simple, clear, and shows the pathophysiology.
Exactly. For PDA, draw the normal boxes. Then just draw a simple connection, a little tube between the aorta pipe and the PA pipe. Draw a red arrow going from the aorta into the PA. Label it L2R Shunt.
Simple, clear, labeled. That gets the marks.
It gets full marks. The examiner just wants to see that you understand the direction of blood flow.
We're coming to the end of our deep dive here. Let's summarize everything. If a listener takes away only 5 absolutely critical points from this hour to carry into their exam, what are they?
Okay, 5 points. Number 1, understand the shunt direction. Is it right to left in cyanotic or left to right in acyanotic? This single fact dictates all of your SVR and PVR management goals.
1. Shunt direction.
2. TOF management is SVR management. Maintain SVR at all costs. Avoid things like propofol boluses and spinal anesthesia. Ketamine is your friend.
2. TOF equals SVR.
3. TET spells. Know the protocol cold. Oxygen, knee chest, morphine, fluids, and most importantly, phenylephrine. Never ever epinephrine.
3. TET spell protocol.
4. PDA physiology. Remember, it's a volume overload of the left ventricle and a flood of the lungs. And watch out for the oxygen trap in premature babies. Don't overdo it.
4. PDA is a wet, volume-loaded state.
And 5. Safety. No air bubbles in your IV lines, ever. A paradoxical embolism from an air bubble is an unforgivable, preventable catastrophe.
5. Meticulous de-airing. Okay, and a final word for that exam candidate staring at the book tonight feeling completely overwhelmed.
Don't panic. CHD is just plumbing. It's all about flow and resistance. If you get stuck in a question, if your mind goes blank, just go back to first principles. Ask yourself, where is the blood going? Why is it going there? And how do SVR and PVR affect that flow? If you can explain that core logic, you will pass. You might even get a gold medal.
It's just plumbing. I'm going to keep telling myself that. That was a true masterclass. Thank you so much for breaking it down like that.
My pleasure. Good luck to everyone out there sitting the Gujarat University exams or any anesthesia boards for that matter. You've got this.
And for all of you listening, maybe re-listen to that TED spell section one more time before your Viva. That's it for this deep dive. We'll see you next time.